Welcome to Total Worker Health Intervention Research Employs a Hierarchy of Controls. We're glad you're here. My name is Yusra Benjeloun, Administrative Coordinator and Project Manager with the Work Wellness and Disability Prevention Institute, and I'll be moderating the webinar today. This webinar is made possible through the support of the Community Cayman Grant Program through the BC government, as well as donations and memberships to WWDPI. We thank our program partners, Canadian Council on Rehabilitation and Work, Education Advisory Committee, and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We will collect questions submitted throughout the presentation and follow the presentation with a Q&A based on questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You will be emailed the direct links for all of these items when they're available. As I mentioned, my name is Yusra, and I'll be moderating the webinar and Q&A session. Our presenter today is Dr. Kent Anger. Dr. Kent Anger has a PhD in experimental psychology from the University of Maine and served in the Public Health Service as a scientist director in the Neurobehavioral Toxicology Research Section at NIOSH before joining Oregon Health and Science University as the Oregon Institute for Occupational Health Science Associate Director for Applied Research in 1989. He has been continuously funded since shortly after joining the Institute and has over 90 peer-reviewed publications in behavioral neurotoxicology research and total worker health interventions. And now I will hand it over to you, Kent.
Okay, Yusra, thank you very much, and thank you for all their calling in to listen to me. So the name of the title of the presentation, Yusra has mentioned. Our interest was in looking at how the total worker health interventions related to the hierarchy of controls, which has been so important in at least U.S. occupational safety and health for so many years. I'll draw your attention to the conflict of interest statement on the first slide. I will talk about some things that I have developed in my laboratory and then created a small company to license it to be able to bring in additional funding to support the work and to disseminate it. So a conflict of interest there. And then I can earn money from that. What total worker health is, because that is a term developed in the United States and may not be familiar to you. And certainly it isn't even extremely familiar throughout the United States. And the U.S. NIOSH, National Institute for Occupational Safety and Health, basically, for the U.S., we defined occupational safety and health in 2011 and then modified that in 2015 and developed the name for it of total worker health. Occupational safety and health essentially becomes occupational safety and health and well-being. So that's the addition to it, is and well-being, to the original concept of occupational safety and health as we've been using it in the United States, as well as other places. And the foundation remains safety in the workplace, but there was really a struggle in the early days, because NIOSH originally defined total worker health as health protection, which is occupational safety and health, and health promotion, which sounded a lot like wellness to people. And so that was a problem for a lot of safety professionals, thinking that it was focused more on health promotion than safety. And so the safety specialists were worried that safety would be lost when this new element, described as wellness and health promotion, was coming into sort of the occupational setting. And paired with safety. So NIOSH, recognizing that they had made a mistake, yes, agencies can make mistakes and recognize them, and so they redefined it as well-being. So it became occupational safety and health and well-being, and that then people began to understand the meaning of it, and increasingly, and didn't get stuck on health promotion as a concept. Increasingly, with this new definition, occupational safety and health practitioners around the United States and company management in the United States really began to get that. They see that total worker health works to improve sustainability, engagement, and productivity of the workforce. In other words, being concerned with the worker safety, health, and well-being improve the workforce and their sustainability and their productivity. It wasn't just it wasn't taking away from that in any way, but enhancing it. That's, I guess I should say, more a hypothesis than a proven fact, but that's kind of what people are believing at this point. So what are the concepts behind total worker health? Let me expand on that a little bit. Safety, health, and well-being are not just workplace-only concepts. The idea is that what happens at home affects what happens at work and vice versa. Our job's a major determinant of our health and well-being, as is our lifestyle. Another concept behind it is that, and this has demonstrated information now, is that unhealthy people have more accidents at work and at home and take longer to recover. Private companies that prioritize well-being perform better in the stock market. They also thrive as companies. Evidence indicates that a focus on total worker health increases employee engagement on safety and on their health as well. Total worker health supports safety, health, and well-being at home and at work. It says to employees, you are important and your success in life is important to the business. We want to help you succeed in life at work and away from work. So these are kind of the concepts behind total worker health, or that have emerged as being the sort of the key concepts behind total worker health and the value and the benefit of it. So we set out to assess the total worker health intervention literature since it was defined back in 2011. And of course, the predecessors of it were elements of total worker health as well. They had developed, and so we'd begun to have a literature that we could look at and say, is this being successful? Because we're not saying, and NIOSH is not saying total worker health is a proven value. It is a recommendation, the value of which needs to be proven, and so is it being proven? So we use the following search criteria to look at the literature. The intervention, as all intervention literature, had to address, in other words, attempt to change both traditional safety and health and well-being issues. There could be cross-cutting targets like stress and sleep and sitting, where we judged as cross-cutting targets as being related to both safety and health and well-being, or each of those concepts. And so we judged them that they simultaneously address both the sort of a traditional occupational safety and health as well as the well-being concept. The intervention had a degree of integration between safety and health and well-being. That is, they weren't just two separate programs or different separate programs set out there that didn't really speak to each other, but they were related to each other either in the same program or in related programs in some way. And the studies had to be quasi-experimental or randomized designs. And the publications had to be in English. So those were the search criteria that we used. We had, so let me give you an example of what an integrated total worker health intervention would look like. And I'm using one of my own because it's I can use it without asking permission, and because it's easy for me to explain. So this is an integrated total worker health intervention, I should say. So it is a project that involves point 1, effective supervisor training at the top of the slide, and then further on down, point 2, the work crew gets Get Healthier training. So we begin with part A, with part 1. They begin with tracking behavior, and you see sort of a picture of a training screen in the training program I've developed, and then to the right is a tracking app developed here at OHSU as an enterprise app. And our goal here was to get supervisors to interact more frequently with their workforce, with their employees, and to not just talk about work, but talk about family and outside things of work as well, to develop relationships, interrelationships between the supervisor and the employee, especially if that wasn't happening, or if it was, to enrich it. And so for the first couple of weeks, we asked them to just track how frequently they interact with their workers, their employees, and kind of what they talked about. Was it about work, or was it about outside of work? And then part B is that we gave supervisors training in how to interact more effectively with their workers and to reinforce appropriate behaviors, and to sort of supervise in a more effective fashion than a fashion that is not infrequent, where the supervisor just tells them what to do and then waits for them to make a mistake and then complains that they made a mistake. Rather, we focus on reinforcing the effective behaviors, the appropriate work practices. So at about the time we did that training, then we also developed Work Crew Get Healthier training. And we had the workers, the employees, come around in a table, sort of at the bottom of the screen, to discuss topics with scripted training. And the scripted training topics I've just put up on the screen were sleep, calories, basic nutrition. So in each of those topics, liquids, fruits, vegetables, snacks, exercise, strength training in the home, and motivation to continue was at the end of it. So these were Get Healthier topics that we wanted people to learn about. And so there was a little card shown on the right-hand side, an example card. It was a two-sided card that had a whole series of information and questions on it to build people get people to discuss things. So and that went on for about 12 weeks, 11 or 12 weeks, with one card per week. At the same time, then the supervisor was encouraged to reinforce appropriate safety work practices of their choosing. Might be wearing hard hat more frequently, or when it was needed, I should say, or something like that they felt was important, and it could be different for each worker. And then after a while, to then start transitioning to reinforcing healthy lifestyles. Hey, Bill, I see that you've brought some lunch from home rather than going to the local fast food area. That's really great. Glad to see you're doing that. You're really being healthy. Sort of doing things like that. So, and that went on for the 12 weeks of it. And then so we gave surveys at the beginning and end. But anyway, that's kind of an integrated intervention where the two parts of it, the safety part of it and the health part of it, and the Get Healthier, or the well-being part of it, were really all part of a single intervention. So that's just one example. There are a lot of other types of interventions, but it's one example to sort of see how the integration concept works out. So now back to the literature search. I've shown you the search, the criteria that we used to search for. Now, what was our search strategy? Well, we started out looking for all the individual issues that NIOSH has identified as being part of well-being and safety and health, and it is a huge number of topics. And so we tried to get in the literature and search for all of those, for interventions that used all of those integrated with both safety and health and well-being, and it was just a massive task. So instead, we pulled back and said, let's just look for the concept of total worker health, or the term total worker health, somewhere in the article. And we used Google Scholar, PubMed, Scopus, PsycInfo, and those are the number of hits we got. Now, we didn't expect to get a huge number, but we also looked at the NIOSH from that, but we want also to enlarge that number of studies that we were looking at. We went back to the 6 NIOSH-funded Total Worker Health Centers of Excellence, of which our center is one here at OHSU, and we asked them what studies they were aware of and that they had done in total worker health, incorporated those into the review. looked at NIOSH TIC2 database that NIOSH publishes and for total worker health projects. And then we looked at the systematic reviews of total worker health from 2015, one that our group did, that I led, and Feltner et al. In 2016 that was funded by by an NIH group. So we looked at and we took all the studies that have been considered total worker health in those two reviews. So together we brought all those together and looked at them and say which matched our criteria. And we found that when we looked at the 2015 using the same criteria, Anger et al. 2015, the picture of the publication is sitting up there, we found 17 articles. Now, 2 years later, in 2017, at the end of that is when we were finishing, completing our review of the literature. We found 37 articles met the criteria. So we'd found 20 additional articles in the 2 years since that time. And we felt that was a good set of articles to evaluate the effectiveness of total worker health interventions. So we will first talk about these 37 studies. I'll go back to that. We're going to talk about the 37 studies and kind of summarize what we have found in those. And then towards the end of the presentation is when I really will get to the hierarchy of controls part, because that's sort of imposing an external assessment of the studies. So we first asked, what was the intervention goal that the studies had that we were looking at? And the most frequently used intervention goals, or most frequently identified intervention goals, were to reduce sitting and increase activity at work and stress management. And there were 4 studies that could generally address those particular issues. And the other one that a lot of people were doing was to introduce participatory interventions that involve both management and labor representatives. And really, they used the Kaizen method, and it wasn't that they had a specific intervention that they were implementing. It was a process that they were developing so that companies, organizations with labor could develop their own interventions. And then just to mention some of the other kinds of ones there were, just to give you a sample of them. There was one that did company-wide restructuring, added physicians into the process, and had people get annual or periodic meetings with physicians to go over their health, and with safety specialists to go over things. And I mean, it was just a massive restructuring of how they did things. So that was one type of the intervention. There were some on ergonomics and safe patient handling that people did. There was smoking and smoking cessation or reduction and hazardous chemical reduction, looking at hazardous chemicals that synergized with the carcinogenic chemicals in smoking. So these are the kinds of studies that people were doing, or the goals of the studies was to improve things in these areas. So what were the research designs? Well, of those 37 articles, 21 of them were randomized trials and 16 were quasi-experimental studies. What about the sample size? It ranged from a low of 16, which is pretty low, to a high of over 43,000, which is pretty big. So the median was about 264. If you looked at the sample size across all the studies, it was about 264 people. What about the locations? Where did they take place? Well, most of them took place in the United States. Not surprising, perhaps, because it was not in the United States where that term was defined by NIOSH, and so that focused the occupational safety and health community on doing total worker health interventions. But there are in other countries, not in Canada, but there are some in other countries as well who essentially adopted what was a total worker health approach. What about the industries? Are they is it distributed among different industries? And the answer is yes, a lot in healthcare and manufacturing, some in transportation and construction, and then sprinkled around, and one in finance, one in corrections. And then there was really a large group that fall in the other category in the standard industrial classifications, which is what we used here. And that was government workers, maintenance workers, office work of various sorts that couldn't be identified as being in a particular industry. 13 of those. So this is the distribution in the industries of these different studies. So what about the dose? What does it take to do an intervention of this sort? How much time does it take to that the employees and our supervisors have to commit, and our managers have to commit? Because that's always the first question that's asked is, how long is it going to take? How much time do I have to spend? And kind of my answer is, well, if you want a transformation in the way people work, it's not going to be done in 30 minutes. You know, it takes time to make changes, significant changes. Nonetheless, there was one that was significant in young workers in particular that just took an hour. More often, they took 2.5, 4 to 8 hours, 12 hours, 30 hours. Some took a really lot more hours over a longer period, fairly long period of time. One study, which was one of those Kaizen studies, had periodic sessions over 5 years, sort of an ongoing restructuring of the way the workplace worked, bringing management and labor together. And then another one just identified 18 sessions without the time identified. So this, I refer to this as the dose, because this is what it took for those interventions to take place. How much time commitment had to be provided from a lot of employees, in most cases, and a lot of supervisors. So this is like on a per person basis in some sense. So how is it delivered? Well, most of them were live or in person. 31 out of the 37 were pretty much exclusively live or in person presentations. They're all, in addition, some studies use just online platforms, paper-based interventions where, like with the cards that I mentioned in that first example, that study's not included in here because it wasn't published at the time, but you know, some paper-based approach to giving people information on paper. And the advantage there is that they can then take it with them and take it home. In some case, the work environment was changed substantially, building exercise facilities, putting healthy food in the cafeterias, making changes where you had standing meetings or sit-stand desks, things where the work environment itself was changed. That was sort of the delivery mode, was the change in the work environment, workplace. And a lot of it was involved organizational changes in, for example, supervisors were trained to be more effective, like in the example that I gave at first. And they were mostly used in conjunction in some way with some kind of in-person contact. So in-person contact was really in virtually every program that was involved. Who was the target? Well, mostly it was employees. There's one study that focused only on supervisors, but there were 16 that's focused on supervisors and employees, and then 10 that addressed supervisors and managers and employees sort of across the organization. Integration. So I mentioned that as being kind of a high, an important factor in what we're doing. And in integration, we really did a subjective assessment because the articles didn't really bring out that information. And we judged, and we did a consensus judge where two people evaluated the article and then both gave scores, and if they were different, we came to consensus on it. Well, we thought about 19 of them had high integration. They really did have the safety, health, and well-being kind of integrated into a package in the intervention delivery. Medium 8 and low 10. So that was our subjective assessment of it, but consensus assessment. So what about the evaluation of total worker health effectiveness? How did we evaluate that? Well, only 2 of the studies compared an integrated total worker health program to either a safety-only program, that was Cara et al. From 2016, or a health promotion-only program. And this was in the days where it was being called health promotion. And the health promotion-only program was Sorensen et al. In 2003. So the rest of the studies were comparisons of a total worker health program to a control, for example. So there wasn't an integrated program that was compared to a safety-only program and a well-being-only program. So in other words, safety-only, well-being only, 2 different groups, and then a third group has those things crashed together in an integrated program and then a control. That just didn't happen in these studies. So we feel that in order to really say a total worker health approach is effective, that we really have to have this kind of factorial design kind of study to come to a clear conclusion. That said, as time goes on, companies are more and more, and practitioners and scientists are more and more convinced that the total worker health is effective from looking at a lot of different measures. And so it seems, and so it is going forward in the United States. It is a growing approach. So finally, we get to the hierarchy in occupational safety and health. So let's talk about the hierarchy of controls. I'm assuming that the hierarchy of controls is a widely used concept, but I really only know what's going on in the United States. So I will say the way we've approached it in this country, driven by NIOSH particularly, and OSHA just to a large extent, and the state OSHAs to a large extent, is that when you're trying to develop a process, you should, or improve a process, you should approach it in the following way. You should start by eliminating the problem, whatever it is, be it a safety, a health, or a well-being problem, that you eliminate what the problem is. So if the problem is a chemical exposure to a toxic chemical, then you pull that out of the process in some way. You physically remove the hazard. The second most powerful one is to substitute something else for that hazard. So you take a toxic chemical and substitute it with a less toxic or a chemical without known toxic properties. Third, engineering controls. You isolate people from the hazard. You put people in a box, or you put the process in a box so that the people and the process are separated by an engineering control in some manner. It could be just a fan sucking the chemical away, for example. Just following that sort of concept of a chemical as an example. Administrative controls, you control the way people work. This is often a policy stated by the organization to say, you will not do this, you will not be in the area when that chemical is in use. And so that's the sort of traditional administrative control. And so it's less effective, and that's why you start with the most effective, elimination, substitution, and work down it. And then sort of the last resort is PPE. You protect the worker with a personal protective equipment. The respirator being the obvious one for chemical exposures, or gloves for chemical exposures as an example. So this is a traditional hierarchy of controls that we in the safety and health business have used for certainly since 1970, when the OSHA Act in the United States occurred and got the United States kind of moving in a consistent direction. We're a little behind the rest of the world, but anyway, that was our way of accomplishing. That was when we started really getting serious about safety, in my view. So now that's been adapted for total worker health. How's it been adapted? Well, it's been changed so that the first couple of sort of control methods are listed first. as still the most desirable, the most effective, and that's to eliminate whatever the working condition is. If it's too much sitting, which has safety, health, and well-being, then you provide standing desks and give people walking meetings and give them ways that they don't have to sit down to do their work. Substitute health enhancing policies, programs, and practices for whatever was going on before that. Redesign the work environment for safety, health, and well-being. So these are very similar to what you saw in the previous hierarchy of controls pyramid, upside down pyramid. And the two particularly new ones are educate for safety and health and well-being, and encourage personal change, or encourage change, behavior change. So that's the kind of the inverted pyramid adapted for total worker health. So let's look at both of them together. So eliminate, substitute, redesign engineering controls, educate administrative controls, encourage versus PPE. So that's how NIOSH revised it or adapted it for the total worker health concept. There still is a hierarchy of controls. Eliminated, the base of the pyramid is still the recommended one to make changes if at all possible, but if not, then you move to less powerful controls, less effective controls. So how did these studies rate? We took each of the studies, not that any of the studies even mentioned the hierarchy of controls, but we took each of the studies and said, based on this hierarchy, eliminate, substitute, redesign, educate, and encourage, let's fit their intervention methods into those boxes of eliminating things or substituting things. So how do you think it came out? Where do you think the most frequent, the most frequently used control method was? Eliminate? Probably not. You're thinking, I'm guessing, but this is where it'd be nice to have an audience where we can see hands pop up. But at any rate, I'll tell you what we found looking at the articles. And again, we have two people looking at an article and then judging that article, and then putting the intervention pieces into the boxes of eliminate, substitute, etc. So only one method of control. First, to look at that. How many just use only one method of control of those 5? Only 3 studies did that. How many use 2 methods of control? 17 studies used that. 3 methods, 13 studies, all 5, 3 studies. So people tended to use more than one method of control. And it isn't like you have to do just one thing. We are talking in these interventions about not just simple, really simple, basic minor changes, but larger changes, more programmatic, bigger sorts of changes. So it's not surprising that people use different methods, control methods, multiple control methods for that. So what about the individual ones? How many fit into that box? And so here, because some use more than one, most use more than one really, you'll see the number is going to come up to more than 37, but 4 of the studies used eliminate. So of those studies, very few of them could actually eliminate the hazardous conditions, both safety, health, and well-being conditions, but some did use that. Like smoking cessation is one of them. New policy, no smoking in the location, in the job, as at my university. What about substitution? Substitute 8 studies used that. Redesign of studies, 20 used that. Educate people. Now we're beginning to get most of the studies use education of some sort. And then an awful lot of them used an encouragement of encouraging personal change, sort of intervening at the level of encouraging people to make changes in the way their work practices or their home practices, their lifestyle practices. Okay, so have the interventions been effective? Let's get back to that question. All 21 randomized trials resulted in positive changes. Virtually every study involved resulted in positive changes. Only 6 of the articles reported measures of effect size, and most of those measures were, most of the studies that reported that, articles that reported that, came from my center, our center here at OHSU. So they will be kind of in our examples. And let's look at some examples of those that used effect sizes, either the Cohen's effect sizes or R squared. So in one study of construction workers that we did, a total worker health study of construction workers, Leslie Hammer study, in construction workers, there were blood pressure decreases across the board in the construction workers. And that was one of the foci of the intervention, was to improve supervision, more flexibility, helping people be more attentive to their individual needs, and as well as lifestyle changes and sort of work process changes, and to an extent, but more safety changes than anything. And blood pressure decreases were found, and this was at, I think, 6 months after the intervention had completed. Home care workers, another study of home care workers by Ryan Olson. These are the changes that he found in that program. A community of practice, he wanted home care workers who are distributed. They're lone workers, they work remotely in people's homes, so they don't have an organization behind them or where they're working to help them, like safety specialists and health and well-being specialists at all. So they encourage them to come together as a group in small groups that were close to each other. So the effect size there was 0.36. Remember that in effect sizes, Cohen's effect sizes, 0.2 and above is a small effect. When you get to 0.5, it's a medium-sized effect. When you get 0.8, it's considered a large effect, based on a review of a lot of different studies. Increased conversation with the supervisor on safety. That was one of the things we focused on that he focused on in the study. And the supervisors were essentially the clients, the people at home that had whatever the disability was, or whatever it was that the home care worker was supporting or caring for by helping in the home. Correcting unsafe conditions, using new or safer tools, medium-size interventions, effect sizes, I should say. And increased fruit and veggie consumption, which we've really found in a lot of our studies that we've done. It's effective in getting people to change. Was a small effect size, but still kind of a notable one. And then increasingly bringing food from home. In another study in transportation and drivers, also done by Ryan Olson, he was focused on reducing weight. Truck drivers lose a lot of weight, or gain a lot of weight as they begin driving and just kind of continue. So he focused on that as a healthy. There was a safety thing on fast braking and so forth, but so there was both safety and well-being kinds of things. So you also see an increased fruit and veggie intake and physical activity with small effect sizes. So each of our interventions are from the Oregon Healthy Workforce Center, are available as a toolkit on the Your Work Path website if you were interested in them. I'll mention that again at the end. So conclusions, what kind of conclusions did we come to with all this? Well, and these are in the notes that were sent out to you as things to conclude from the or primary information that you get from this webinar. And the first one that was mentioned is that the total worker health intervention tactics from each hierarchy level produce measurable positive changes in the workplace. Now, I didn't really explain that to you, but since give you specific examples, but because all the studies used multiple hierarchy levels, almost all of them did, and each of the studies actually did come out with positive findings. There may have been one that didn't, but since virtually all of them did, then from each hierarchy level, there were measurable positive changes in the workplace in these interventions that use multiple hierarchy levels. Second, the majority of these total worker health interventions have employed control tactics or methods classified as educate or education, which was not quite the least preferred tactic. Encourage was, but a less preferred tactic. But still, how are you going to get it done without it? You have to have education of some sort. So it's really, in my view, a key part of the toolkit in any intervention to educate people in whatever it is the intervention's about. Most interventions have used more than one control strategy from the hierarchy of controls. So you've seen that really clearly, I think. And then most interventions were aimed at employees, often combined with supervisors. Total worker health interventions, usually the safety changes may happen where the company implements them or figures out ways to add engineering controls or improve work practices. Oftentimes, of course, the workers come in and identify good work practice changes. But when you get into the well-being area, really supervision and management has to be involved. And improving the sort of effectiveness of supervisors and the in a variety of ways is one of our key management kit in our toolkit, is one of our key management drivers or changers. So that's part of the reason why so many of these were aimed at supervisors as well as employees. Too few studies are reporting effect sizes. People report significant changes, but they can be really small changes. You really don't know for sure without some measure of effect size that looks at it against the total variance involved in the measures that are taken. So we really push and this, what I'm presenting today is part of a chapter that's being published in the summer in a NIOSH book that I'll mention at the end. And we're encouraging there, and we have in our 2015 publication, report effect sizes, give us some handle on how effective the interventions were. And then finally, that there's been no factorial assessment of the total worker health components separately and together. And integration is rarely addressed. So this is kind of the weak areas, and also it's kind of a gap where additional work would be highly prized, I think, at least. And if I were a journal editor or a journal reviewer, I would certainly enjoy seeing that. Think it would benefit the field greatly to see more in that area. And finally, there's no assessment of the size of the dose. I showed you the range of doses, from 1 hour to 5 years, and nobody's really looked at how much of a dose does it take to really change a management structure, to change safety climate, to change kind of healthy lives, get people living more healthy lifestyles, doing more standing than sitting, things of that thing. There's no assessment of how much education, how much training, how many do we need incentives. That information, nobody studied that at all, and that's really a major gap. So these are the two areas where I think people doing work would be beneficial to the field and to our understanding of the value of total worker health. So finally, for contacts and ongoing, up in the top left of the slide, show the 4 interventions that our Oregon Healthy Workforce Center has developed and have provided as toolkits, and you can go to the address under there /OHWC to find those toolkits, and more easily and more in a better way, you can also get them from our dissemination work website, which is www.yourworkpath.com. You see a picture on the right of one of the pictures of, and all the tools, because we have tools as well as toolkits, are all in there and readily easy to find. And then my contact information is on the left. The authors of this chapter, which is in the NIOSH, shown at the bottom, the NIOSH APA book coming out in 7/19, Total Worker Health Integrated Prevention Strategies and Occupational Safety and Health. That'll be available, they think, in July 19, though it has been delayed a little bit as we've gone on. But anyway, this information that I presented to you will be in there in detail, with detail about all the studies. And again, my contact number is anger@ohsu.edu. And so, that's my presentation. And hey, look, it's 45. I've hit my mark.
Great. Thank you so much, Kent. Very interesting presentation as always. So we'll be starting our Q&A session right now. So all of our attendees, if you have any questions, please insert them in the question box. Our first question would be, so you mentioned that the first phase in total worker health integrated interventions was to track the behavior. So what key aspect do you focus on, and how do you quantify them in order to bring positive changes to them?
Good question. So in terms of interventions, well, an example is that we've used the scripted training, where we've given people specific information and then asked them questions before we give them the information and after we give them the information, to see if they knew it at the beginning, and if not, if they've learned it by the end of the presentation. And we've also used incentives to get people to do things, like we have them go home when we're trying to get them to improve their lifestyle, get a healthier lifestyle, giving them take-home kinds of activities, and then giving them a gift card when they bring in that activity completed, so they didn't do it at work, they brought it back home. Different studies have used incentives to get people to change their behavior. Other studies have used taught the supervisors to use social reinforcement to, first educate, make this change, please change the way you're doing this practice. Please, we've got a sit-stand desk here. We want you to have the opportunity to stand more, and we encourage you to stand more for your health and to prevent back injuries and things of that sort. So, and then incentivizing the frequency of that. In one study, there were incentives where there were competitions for work groups to sort of change their healthy lifestyle practices, and they competed against trucking groups. One competed against another, and then the one that had the most walking and the most eating healthy foods and things of that sort, and the least hard braking, which was the safety part of it, they got something that they selected, which was a sort of a heavy coat with an emblem on it from the company that was highly prized by the workers. So anyway, that's a kind of a combination of the kinds of things that were done. In most cases, in very few cases, have people actually gone out and measured behavior. But in some cases they have. And when that's been done in these, not necessarily in the total health studies that I've presented today, but in those studies, they have found behavior change that was recommended by the training or educational component of it. So I think these sorts of things sort of tell you sort of how you intervene to change behavior, and then how you measure it at the end. We do use a lot of surveys, standardized surveys, and you can get information from me on the standardized surveys we've used in a variety of projects. We have a sort of a standard set of surveys that we use, so we can do cross-study comparisons.
Okay, thank you so much. So you're saying the surveys are public, so we can access them?
Yes.
Standardized.
Yes,
oh, perfect.
Yeah, they're built with guides on how to do them. So we've taken the research protocols, which are dense, turgid, oh my God, and turned them into what we think are fairly engaging guides for people to use. We even have some videos on how to do things, and we're in the process of improving those all the time, because we are going from being researchers to trying to disseminate things, and researchers are not known for their light, airy presentations of things. So we're working on those toolkits, but there are guides. The how to get the materials are there. You don't have to read our research articles at all. It's all available.
Okay, perfect. Thank you so much. Another question. So how to overcome the current limited education focused total worker health interventions?
Well, first of all, I do think education is kind of essential to these things because you are trying to get change in both organizations and in individuals. So at some point there have to be their education has to be part of it. But there are things you can eliminate. There are things you can substitute. An obvious example in substituting is the vending machines in companies that often are just filled with candy and chips and things like that. All the things I love. Anyway, is to replace them with apples, and so that there's some healthy choices that are available, and to do the same in the cafeteria. So there are ways you can substitute things that are that are possible. I guess I'm using mostly health promotion kinds of examples, but I mean those are the most, I guess, easily obvious examples. And I think it is just pushing people to, every time they start an intervention, to say, measure it against the hierarchy of controls. Look at the most effective things and try and see what you can do there. And if you can't use elimination, move to substitution. If you can't move that, move, to sort of make that the recommended approach is you begin with considering what the problem is and how the hierarchy of controls might be used to as a guideline for picking intervention methods. So
Makes sense. Next question is, usually how do employers respond to integrated interventions?
We've had a lot of success with people being liking the integrated interventions. They do like the supervisor training a lot because they recognize their supervisors are not necessarily the best. And usually supervisors are brought in because of their technical skills, not because of their supervisory skills. And so they tend to like that, and they do like the idea of process change. As long as they're in some control of it, which of course they always are. So they tend to like that, and the idea of bringing safety and health and well-being together. People like the concept. The only sticking point is the time. How long is it going to take is kind of the first question. And so it isn't so much the integration that's the problem, it's the amount of time they have to invest in it. As I said at the beginning, if you want to change the process, if you want to improve the process and change the work practices and behaviors of your workforce from the CEO down to the person who is on the shop floor, or up to the shop floor, depending on how you think that. It takes time. You have to invest some, because we humans, we grow up and we do things and we learn how to do things, and we get so set in our ways that it takes something to break those out. So integration, they're really pretty enthusiastic about. Time, that's the sticking point.
Okay, so which brings it to, I know you said there's no assessment regarding the doses, but do you have any idea, or in your opinion, which of the doses and delivery modes that you've mentioned were the most effective in your opinion?
Yeah, it's a good question. So the dose really depends on what you want to change. How big a change do you want to make? How cross-cutting, do you want to change a lot of different things or just one little specific thing? And the more you want to change, the greater the dose has to be. So that's really my thinking about dose. I'm sorry, could you say that question again? I'm sort of forgetting the last part.
No problem. So the question was which of the doses and delivery modes that you've mentioned was the most effective?
Yeah, okay, thank you. So, well, most of them used in-person training, and so or in-person interventions, and so that's good and bad. The big problem with in-person interventions is that they don't scale real well. You know, it's kind of hard to get people trained in what they want to do. Let's say the intervention starts in HR, the intervention starts in safety, uh, and so you got just a few people who know what they're doing. Now, suppose you've got dozens and dozens of units somewhere. How do you get that out to those dozens and dozens of units? Train the trainer? Well, then each time you do train the trainer, you're losing a little bit of the sort of expertise and quality of the people who really know what they're doing in the intervention and know what the goals are and so forth. And so you've got scaling problems with in-person work. I personally developed a lot of computer-based training, and I found it effective. I've got good effect sizes. I've got behavior change related to the training I've worked on, but I also have a very specific series of behavioral principles, behavioral education principles that I believe need to be in that computer-based training. And so I've developed a format that can do that easily, but pretty much any training program can use those principles. If you find any of my publications in Total Worker Health, they will be mentioned in those publications. So I believe computer-based training scales better. Sitting in Oregon here in Portland, Oregon, have I ever gone to Burns to give a presentation? No, but they can get my computer-based training there. So if you sort of limit yourself to only in-person training, you limit the scope of your audience, the range of your audience tremendously, and that's why I believe you need both. You really need to have it in a computer-based format, the training and the so forth, so that it can go out. You can package it up and send it out beyond your immediate range of activities. So anyway, I guess I'm saying that they're all valuable, but in person is certainly the most effective in many ways because you can get question and answers if it's a good presenter. But you also need to be able to scale and go beyond your immediate purview. So you need some way of doing that.
Thank you so much for your explanation, Kent, for presenting this webinar, and thank you for your hard work. Would you like to add anything at all?
I don't think so, Yusra. I just thank you for making it easy to make this present this information, and to the audience for kindly spending the time to listen to my presentation. And I encourage you to look for that book in July 2019, Total Worker Health Integrated Prevention Strategies in Occupational Safety and Health, where you can learn a lot about total worker health, including what I've talked about.
Perfect. Thank you so much. To our audience, thank you for joining us.